So the topic for presentation today, as we all know, it is MIS fusion in revision spine surgery. So the article which I have selected here is an original study in 2019 December issue of Journal of Spine Surgery. So it is by Lee et al. Minimal invasive surgical algorithm for revision lumbar spinal surgery. So he is a senior consultant spine surgeon and head of spine surgery unit from Stanmore Royal National Orthopedic Hospital. So this one is an original article which is taken from Journal of Spine Surgery from December 2019 issue. So to start with the introduction, as we all know, elective spine fusions are on the rise. One important issue being the aging population, and we have extended our indications depending upon the aging population. And there is an improved perioperative care these days. So, you can manage what kind of fusion you're doing, and whatever comorbidities the patient is having, you can manage perioperatively, because we have an improved team to manage that. And revision following a primary spine fusion, it ranges from 8 to 45%, which has been taken from multiple articles, and it increases with a greater follow. So what are the causes for revision? So it may be a recurrent disc or a recurrent stenosis, non-union at the fusion site. It may be due to infection, adjacent segment disease, which is very extensively discussed everywhere, and implant failure and flat back fusion. So revision surgery in spine is a challenging thing because it tends to produce much more complications, even if provided the baseline characteristics of the patient are same. So the method which they have used to formulate this algorithm, so they have been practicing this MIS in revision spine surgery since 2012. So half of senior authors practice being revision spine surgery. So every patient which they have included in this study, they have evaluated the patient with the history and the clinical examination, and particular regard to patient's expectations and what is the previous non-operative management that has been done. And they have evaluated again these patients with a full spine standing radiograph, which is an AP and lateral, and if possible EOS imaging, which is from Paris, and MRI and CT also. MRI to evaluate the compression and CT to evaluate the facet morphology and also the bony fusion, and also how much bone stock is available if we are planning for a recurrent procedure. And again, the important thing which they have done is all these patients who are with risk factors for osteoporosis, they have been evaluated thoroughly with bone scan, and if they have found out it is greater than minus 2.5, they have done a pre-treatment before advocating any treatment. So coming to the surgical algorithm which they have formulated after reviewing through all these patients and operating these patients since 2012. So they have categorized these patients into two categories. The patients who have undergone previous decompression alone and the patient who have undergone previous fusion. So again, in this decompression category, they have divided these patients into number of decompressions, whether 1 or 2 times or multiple times of decompression that has been done previously. And again, in fusion category, they have categorized these patients into non-union following a fusion, adjacent segment degeneration following a fusion with a solid fusion mass across the fused segment, and already a flat back fusion which has been done, causing a severe sagittal imbalance. Again, in this decompression category, as you can all see in the screen, so 1 or 2 times of fusion, and you can see here in the baseline thing, where the sagittal profile they have considered in formulating this algorithm for all these patients. So sagittal profile, again, the pelvic incidence minus lumbar lordosis, which is normally more or less same. The difference, if it is more than 25, then they have considered it as a severe sagittal imbalance. And again, sagittal vertical axis greater than 15 centimeters is considered as a severe sagittal imbalance. Here you can see at the left side of the screen, the patients who have undergone 1 or 2 times of decompression, they tend to have a very mild sagittal imbalance, whereas throughout the right side of the screen, you can see the sagittal imbalance that has been increasing. So the considerations were whether decompression alone or fusion, and what is the sagittal parameter. These are the main considerations. And after considering all these things, they are formulating the algorithm now. So if only one or two times, if only one or two times of decompression being attempted, so they advise a type 1 technique. So they have formulated 5 techniques, the type 1 being advising a revision decompression, whichever may be the technique. They advocate a MIS decompression using retractors, and MIS revision, whichever technique the surgeon is comfortable with. It starts from T leaf, L leaf, or O leaf, A leaf. And again, if the decompression has been attempted multiple times, these patients tend to have mild to moderate sagittal imbalance. They fall in this category. So the primary aim is to achieve a sagittal imbalance in addition to neurological decompression. So in these patients, they advise anterior procedure with interbody cages like L leaf, O leaf, or A leaf. Again, if you consider this fusion patients, they have again divided these patients into non-union, adjacent segment, and flat back, and these may intermingle each other. And this non-union patient, again, the primary problem is the non-union across the fused segment. So for these patients, again, they advise a type 2 technique where they advise us to go ahead with the anterior cage by removing all the non-union thing which is there. Again, if the adjacent segment degeneration is the problematic issue, then we have to assess their sagittal balance. So if the segment already being fused is in a good lordosis, if the adjacent segment degeneration is the only responsible feature for the sagittal imbalance, then they ask us to extend the fusion with L leaf, O leaf, or A leaf. And if the fused mass is in a mild kyphotic or in a flat back level, then they ask us to extend the fusion by using hyperlordotic cages. That is, they don't want to disturb the already fused mass, but they want to increase the sagittal profile by increasing the lordosis across the adjacent segments. That is type 4 technique. So the difference between type 4 and type 5 is, by using hyperlordotic cage, they can able to achieve some good sagittal correction in type 4 technique. But even with hyperlordotic cage, if you are unable to achieve a good sagittal profile, they advise a open technique with osteotomies and extending the fusion, not an MIS technique. This is the baseline of the algorithm which they have formulated. And these are the representative cases which they have given in their journal. So this is a type 1 technique that is being followed for a L45 already being decompressed now with the right-sided disc. I don't know how many of our panelists will agree to this kind of management, but still here the sagittal profile is maintained and they have done a MIS T leaf. You can see the thing. And this is a type 1 technique where previous single level decompression being done. Now multiple decompressions being done, you can see over here, and there is a kyphotic alignment of the lumbar spine rather than a good lordosis. So they have done multiple level anterior fusion to achieve the sagittal alignment. This is a type 2 technique. And here it is a type 2 technique again, which is followed for non-union. You can see a translucency around the screw, which has been already placed over here. So they have revised the screw with a greater diameter and they have done an anterior interbody cage. And this one being an example of type 3 technique that has been described by them. So this is basically an adjacent segment degeneration with already fused segment is fused nicely in a lordosis and good fusion across the segment. So they just want to extend the fusion. So they have extended the fusion. So this one is a type 4 technique. Here you can see a mild flat back across the fused segment and the adjacent segment is giving a very much sagittal imbalance. So they have used a hyperlordotic cage at this level because this segment has fused already. They don't want to disturb this segment. They have used a hyperlordotic cage at the adjacent level to correct the sagittal profile. This is an example of a type 4 technique. Again, coming to the discussion of the paper. So traditional open techniques for adjacent segment degeneration, overall complication rates range from 40 to 86%. And they tend to have major perioperative complication in 8% of cases. So this paper mainly emphasizes on sagittal imbalance that should be corrected, and achieving a segmental lordosis is a prime importance when you are doing a short segment fusion. So what is the shortcomings of this algorithm of this paper? So they have included these patients from 2012, but none has been mentioned regarding the study group included, what is the sample size, and what are all the patient characteristics. They have not described about what are all the patient characteristics and how they have included, what is the sample selection criteria. All those things have not been included. And again, there is no functional or outcome analysis for their algorithm. This is just an algorithm which they have formulated with their own experience, but no outcome analysis paper has been available till now for this algorithm. And we all know, and sorry to say this sentence, and I hope all the panelists will agree to this, fusion is not the only solution, because the first representative case which I have shown, I hope we can get away with the endoscopic discectomy or a microdiscectomy. And role of endoscopy and endoscopy assisted techniques have not been mentioned in this paper, which is gaining importance these days. So to conclude this journal, we all know minimally invasive surgery is a boon in any surgical field, and it is of prime importance in spine surgery. And we have to tailor all these MIS techniques according to the patient's need and their presentation at that time. And future perspective regarding the usage of endoscopy and endoscopic assisted techniques in managing these patients with revision spine problems should be emphasized. And regarding this paper, there is a need for a functional and outcome analysis before we take into account this algorithm universally.